Hello, and welcome to session 3 of our Friendly Pharmacy 5 book club featuring the book Gut Logic by Graham Mackenzie with contributions by Dragana Skokovic-Sunjic and myself. Thank you so much for joining us today. We're just going to wait for some of you to come in. We've been having these sessions now for 3 weeks, and today is extra special because we have a special guest with us, and I'm going to introduce him in just a moment. But first of all, I'd like to share some facts about the microbiome with you that we've prepared here. Did you know that the human microbiome likely consists of up to 1,000 different species of microorganisms? And the palm of your hand can harbor more than 150 different bacterial species, only 17% of which are common to both hands of the same person, and only 13% of which are shared by different persons. So that's just a fun fact for you. There is certainly a lot to know about the microbiome and about gut health, and that's what we're doing here today. All of these sessions are evidence-based. And so, like I said, we are featuring the book Gut Logic by Graham Mackenzie, and this book is also evidence-based. So here we are not trying to sell you anything. We're not even trying to sell you the book or anything like that. But I just thought that this topic is something there's so much misinformation about this, but there's also so much interest in this. And so our priority and our intention with these sessions is to provide you free evidence-based education on this topic that can help you advocate for your own health. And maybe you're a healthcare professional and you're watching this today, and we really want you to leave these sessions feeling more educated and empowered to even help your patients, right? So I'd like to introduce Graham Mackenzie. He is the author of the book Gut Logic, and he's been joining us for all of these sessions. Thank you again for joining us, Graham. How are you today?
Good to be here. I'm fine, Lindsay. How are you?
I'm doing well. Here on the West Coast, it's nice and sunny,
Mm,
but I know it's not that way for you.
no, not at
Yeah,
all. We've
yeah.
we've had a rough stretch of weather, and only for the eclipse we saw the sun for just a few short minutes, and then it was gone again.
Yeah, and actually next week, we have a special session for you with Graham and Dragana, and I'm going to speak about that at the end of this session. And we're going to talk maybe just shortly about your experience with the eclipse, Graham, because I know you were out there and you took some incredible photos. So just a couple housekeeping items today before I introduce our speaker. Uh, if you would like the transcripts from the Q&As from these sessions, you can go to friendlypharmacy5.com for the transcripts. You can sign up for our newsletter, and that will give you access to the transcripts for every one of these sessions. These sessions are free and they are available, but only for a limited time. So if you haven't seen the previous sessions, try to get caught up with those. And then we have a few more weeks of sessions left here. And I will mention the topics of those sessions after our speaker gives his presentation. Also, Graham, as we've been doing every session, he has volunteered to give away one copy of his book to one lucky audience member. So
Mm.
if you comment in the comments from any of the platforms that we're live streaming from today, you will be entered in the draw for a book, and we will be announcing the winner of that book at the end of this session. So even just leave a comment, let us know where you're from, or let us know what your biggest takeaway has been from these sessions. Also, as we have our speaker presenting, if you do have questions, feel free to ask questions in the comments, and we will be monitoring that. And anyone who asks a question or leaves a comment will be entered in the draw. After our speaker's presentation, there will be a live Q&A session. And so if you do have questions, hang around because we will be trying to get to all of the questions at the end of the session. So I think that covers everything. Again, if you're just joining us now, or if you've been in the previous sessions, say hello, let us know where you're from. We're really trying to, we enjoy engaging with you in the comments, right? So, and we're trying to see what kind of helpful information we can give you, not only in this session, but in future sessions as well. So your comments really do help guide us as to what information you are really looking for. Okay, so without any more delay, it is my absolute honor to present to you today our special guests. Today we have Dr. Damianos from the Mayo Clinic joining us. Dr. Damianos, thank you so much for being here.
It is very much my pleasure. Thank you so much, Lindsay, for having me.
It's such an honor, and Graham and I are so excited to have you here. I'd like to just tell the audience a little bit more about you and about who you are and the work that you've been doing. So Dr. John Damianos is a clinical fellow in gastroenterology and hepatology at the Mayo Clinic in Rochester, Minnesota. Prior to his fellowship, he graduated from Dartmouth Geisel School of Medicine as a medical education scholar. He then completed his internal medicine residency at Yale, where he was awarded Clinician Educator of Distinction. Dr. Damianos serves on the Scientific Advisory Committee of the Alliance for Education on Probiotics, where he writes a quarterly research review on the latest in probiotic science. He has also contributed to the development of curricula for medical and pharmacy schools concerning probiotics, and has given numerous talks on various microbiome-related topics. His clinical and research interests center on microbiome therapeutics in the prevention and treatment of gastrointestinal disorders. Dr. John Damianos is going to talk to us today on the topic of irritable bowel disease. This is something that affects, I believe it's between 25 and 45 million Americans. And Canada, I don't know if you were aware of this, Dr. Damianos, but Canada actually has a higher incidence of irritable bowel disease than the rest of the world. I think Canada is at about 18% of our population, whereas the worldwide average is around 11%. So we are looking forward to hearing from you today. First of all, how did you get into the area of the microbiome and become interested in gastroenterology?
It really all began in my childhood. My father's a gastroenterologist, and so I always had an interest in gut health and gastroenterology. And also, growing up in a Greek family, food was a very central part of my upbringing. And gastroenterology, especially in today's world where there is so much interest in the role of the microbiota in gastrointestinal disease and how diet can impact the microbiota, gastroenterology was a natural path for me. And so it was really a no-brainer in medical school and residency and now continuing in my fellowship. So it's been kind of a lifelong dream, and I'm just so happy that I get to do things like this and talk about the microbiome every day. So thank you again for having me to talk about some of my favorite topics.
Absolutely. And we're really looking forward to learning from you. And I've seen some of your lectures, and they're truly fascinating. You're an incredible educator. So I'm not going to say anything more. I'm going to let you just kind of take over here, and we look forward to learning from you.
Well, thank you. I'm going to be talking today on irritable bowel syndrome, and we could really spend an entire day or perhaps even a weekend talking about IBS. But I decided during this short time that we have together, we could focus on a particular topic in IBS that is one of the most common requests that I get from patients, from other clinicians about the management of IBS. And specifically, that has to do with diet. How does diet play a role in both the pathogenesis and the treatment of irritable bowel syndrome? So let's just dive right in here. So we'll talk about a few things today. We'll go into the basics of what actually is IBS. Then we'll go into the dietary management and what we know about specific diets in the treatment of IBS. We'll then transition to talking about if there are certain dietary supplements that you can get over the counter that can be helpful in IBS. And we'll go deep into the evidence-based data for specific interventions. And then we'll conclude on kind of a higher level note about IBS mimics and why it's important to investigate the individual contributors for any one patient's IBS experience. And then, of course, I'll open it up for questions. So let's dive right in. So I'll be talking about irritable bowel syndrome today, or IBS. This is different from inflammatory bowel disease, or IBD, which refers to largely Crohn's disease and ulcerative colitis, which are diseases of chronic inflammation of the gastrointestinal tract. Irritable bowel syndrome, on the other hand, what we'll be focusing on today is what's classified as a disorder of gut-brain interaction. And I have the criteria listed here. These are the Rome 4 criteria, which are clinical features that one can gather through history that provides a diagnosis of IBS. It's characterized primarily by abdominal pain that's associated by a change in stool form. So constipation, diarrhea, a mix of the two. So it's abdominal pain and a change in stool form. Now, the bottom of this slide here states what in my world is obvious, which is that it's in the absence of any other pathology. So it's not, these symptoms are not attributed to colon cancer or celiac disease or inflammatory bowel disease. So after we've excluded those things, these Rome-4 criteria can help us identify and diagnose IBS. We subcharacterize IBS by the stool form, constipation, or diarrhea. There is a mixed form. However, I'll tell you in my experience, and I can go more into this, that the mixed form of IBS, where there are alternating periods of constipation and diarrhea, tends to actually represent more of a constipation phenotype. And then there's also an unclassified phenotype where you don't quite meet the criteria for other kinds. But again, it's abdominal pain and constipation, diarrhea, or both. Now, as Lindsay was alluding to, IBS is common. There was recently an updated epidemiology study to assess the worldwide prevalence of IBS, and it appears that almost 4% of the world has IBS. There seems to be variability between parts of the world, and there's also more research that has come out recently that looks at sort of subdiagnostic gastrointestinal symptoms. Individuals who don't quite meet the strict criteria that the Rome-4 provide, but who have bothersome gastrointestinal symptoms, and that's up to a fourth of the population who has bothersome gastrointestinal symptoms. So whether it's strictly IBS based on the Rome-4 criteria or other gastrointestinal symptoms, very, very common. 2% of the US meets criteria for Rome-4. If we use the less strict Rome-3, that's up to 20%. So again, chronic gastrointestinal symptoms, very common. IBS is costly to the healthcare system and to individuals and can be rather debilitating. Patients often have to take time off of school and of work to deal with their symptoms. And what's unfortunate, particularly in my world, is that patients often take a long time to get diagnosed, and they're often unsatisfied with treatment options. Even though we have many treatments available for IBS, patients often find that their symptoms are not adequately relieved, which is very challenging. Risk factors for IBS are many. Part of this speaks to the fact that IBS is a very heterogeneous condition. There's a saying in the IBS world, when you've seen one patient with IBS, you've seen one patient with IBS. In other words, no two patients with IBS are alike. What seems to be one of the most important risk factors for the development of IBS is early life trauma and adverse childhood experiences. This includes many different things, including abandonment, physical, emotional, and sexual abuse. These seem to be some of the strongest risk factors for IBS. Another very strong risk factor is food poisoning or infections of the gastrointestinal tract that can lead to long-term changes in the gut microbiome. Diet, as we'll talk about today, is one of the main contributors to the composition and function of the gut microbiome. And certain diets, including the Western diet and a high consumption of ultra-processed foods, has been associated with IBS. Women tend to have IBS more than men. And some of the other risk factors are listed here. But the big ones, again, are early childhood adverse experiences, GI infections, and poor quality diets. The pathophysiology of IBS is very diverse. We characterize it, again, as a disorder of gut-brain interaction. The gut-brain axis is very complex and includes many different components: the gut lumen and the mucosal barrier, the gut microbiota, the immune system, the enteric nervous system, the brain, and the spinal cord. And so dysfunction along any of those components can lead to irritable bowel syndrome. And so this here on this slide, I have two figures that show some of the abnormalities that have been identified in IBS. And again, with IBS being so heterogeneous, patients can have some of these contributors, and other patients can have other ones. It's not to say that every patient has, say, bacterial overgrowth, which we know is involved in some cases of IBS, but another patient might have that. And so, again, investigating the unique contributors to a patient's IBS symptoms is very important. This is another slide that identifies some of the discrete abnormalities that have been identified. Genetics certainly plays a role. We see that IBS tends to run in families, and certain genetic variations have been identified. Food, hypersensitivities, and intolerance I'll go into when I talk about IBS mimics, but this is an important part, particularly in patients in whom diet is a large contributor to their symptoms. And then, of course, the brain-gut dysfunction is at the very core of IBS. IBS is characterized, again, by abdominal pain, and there's no, again, gross inflammation or gross tissue injury, and so the pain is mediated by visceral hypersensitivity, or essentially hypersensitive nerves in the GI tract, as well as central sensitization, where the pain threshold in the brain is much lower. And I've included some of the other abnormalities from intestinal permeability, bile acid malabsorption, altered serotonergic signaling within the enteric nervous system. Many of these abnormalities have been identified. And once again, some patients may have one or more of these that may be different from a different patient's contributors to their IBS. Now, as I alluded to before, we could spend so much time talking about IBS treatments. I'll focus today specifically on diet, but I'll quickly before then say that the treatment of IBS really needs to be multidisciplinary, involving diet and lifestyle changes, medications, and collaboration with other allied health professionals, including gastrointestinal psychologists, registered dietitians, pelvic floor physical therapists, etc. And this is a slide that I've adapted from Dr. William Che, who's one of the leading experts in disorders of gut-brain interaction. And it is an approach for how to counsel patients and work with them in the management of their symptoms depending on severity. Where in the mild cases of IBS, we can provide a positive diagnosis, educate on the brain-gut axis, and work on dietary and lifestyle changes, and perhaps use some over-the-counter supplements as needed. Whereas in more moderate cases, beginning to use medications, and then in the most severe cases, really tackling things from all aspects, that multidisciplinary aspect. Now, that's not to say that we shouldn't engage in multidisciplinary care even in the mild cases, but even in the most severe cases, it seems like those patients absolutely benefit from close collaboration with multiple providers across disciplines to tackle their symptoms. So we'll focus on diet. This here is a figure from the AGA, the American Gastroenterological Association, on the treatment of IBS. It's an algorithm that sort of stratifies by IBS constipation and IBS diarrhea. And I want to turn your attention to that first box that says that really for all patients with IBS, we should be recommending dietary modifications. So diet is a first-line intervention in the management of IBS, including as recommended by our professional societies. So why is this relevant here? Well, it's relevant because most patients with IBS, 84% in this one study, find that food triggers their gastrointestinal symptoms. So there's a very real link between eating and the generation of symptoms of IBS. Now, if you ask patients specifically what types of foods are bothersome to them, two categories immediately emerge. The first is carbohydrates, including dairy, like lactose, lentils, beans, fruits, and a lot of fruits and vegetables. These tend to be triggers for patients with IBS. The second most common category of triggers is histamine-containing foods. So wine, beer, cured meats, cheeses. These two categories are very commonly reported by patients to trigger their gastrointestinal symptoms. Now, why might this be? There are several reasons that food can trigger gastrointestinal symptoms in IBS. One emerging link is due to atypical allergies. And this again comes back to a few different contributors in the pathogenesis of IBS. Number one being food poisoning and GI infections. So in a GI infection, you have a bug such as E. coli, salmonella, etc., that infect the GI tract. There's local inflammation there that disrupts the gut epithelial barrier, increasing the permeability. Normally, the gut has very strict regulation of what is allowed to cross from the outside world, i.e., the gut lumen, and into the body and the bloodstream, which has access to our cells and our immune system. But in a state of increased intestinal permeability or leaky gut physiology, that barrier is broken down, allowing antigens to circulate into the bloodstream and access our tissues and our immune system. And so dietary antigens can lose tolerance in these states of increased intestinal permeability induced by food poisoning. Other states that can increase intestinal permeability can do this as well. And stress is one of those. That's why brain-gut dysfunction, stress is such an important contributor to the generation of IBS symptoms. Part of this has to do with the gut epithelial barrier. And so it turns out that food poisoning and stress and other states that increase the permeability can cause a loss of tolerance to dietary antigens, which means that when you subsequently ingest those antigens, you then get a local inflammatory response mediated by things like mast cells and histamine. And so this is one of the contributors to why food might trigger symptoms in IBS. And there's a lot of research on this front. And one of my favorite studies used confocal laser microscopy to deliver antigens that patients said, hey, these specific foods are bothering me. And the researchers were able to actually deliver the antigens directly into the tissue and see what happens. Well, local inflammation and swelling and histamine release occurs, showing that these really are reactions to food, potentially again driven by that lack of tolerance that occurred through disruption of the gut epithelial barrier. Now, another reason that food can trigger symptoms in IBS has to do again with visceral hypersensitivity. So that oversensitivity of the nerves in the GI tract. We know that among the foods that are most problematic, foods characterized as FODMAP foods, so these poorly digestible sugars found mostly in fruits and vegetables, are not well absorbed in the small intestine. And this allows our gut bacteria to treat them as prebiotics, as food for the good bacteria, and cause gas and water to come into the lumen with an osmotic effect. And this can cause bloating, distension, and diarrhea in patients with visceral hypersensitivity. Dysbiosis or abnormalities of the gut microbiome can further this visceral hypersensitivity and maladaptive response to foods. So these are just some of the reasons that food can trigger symptoms. Wheat is another one that a lot of people, at least in my experience, initially blame gluten. But it turns out that in patients with IBS, the problem is not gluten. It's more of a multifactorial effect, particularly driven by the fact that it's a FODMAP. It's a fructan. It's the fructan in wheat that has that FODMAP effect, poorly absorbed in the gut, drawing out water, feeding the gut bacteria to produce gas. And that seems to be the main driver of why wheat in IBS is associated with symptoms. And again, it is more complicated than that. There are, again, these atypical allergies, as you saw in the other slides. And this slide here just shows some of the mechanisms by which wheat might generate symptoms in patients with IBS. So now that we know that certain foods are a trigger for IBS symptoms, can we use diet then to treat IBS? Well, the answer is a resounding yes. I mentioned that the most common food triggers fall in the category of FODMAPs, fermentable oligo, di, monosaccharides, and polyols. These are poorly digestible sugars that are not absorbed well in the small intestine, which allows them to reach the colon and be prebiotics for the gut bacteria. They feed on them, bringing water and gas into the lumen. And I've included some of what these FODMAP foods here are, but the list is rather extensive. And so since we know that these foods consistently trigger symptoms in a lot of patients with IBS, could we do a low FODMAP diet where we eliminate these foods? And the answer to that is also yes. The low FODMAP diet, there's a lot of information about it online, but there's a lot of bad information. And so I want to clarify some things about the low FODMAP diet. So first of all, I want to make it clear that the low FODMAP diet is the best studied diet that we have in IBS. There's a lot of research showing that it benefits patients with IBS, but it's often done incorrectly. And that's often due to the physicians, and including a lot of GI doctors giving patients the wrong information. So I want to clear up some misconceptions here. The first point to make is that it's actually a 3-phase diet. It's not indiscriminate elimination of FODMAPs and you're done. It's a systematic elimination of all FODMAPs to improve symptoms from a period of 2 to 6 weeks, followed by phase 2, a systematic reintroduction, one group at a time, to identify a patient's unique triggers. Finally, the third phase is personalization, getting to the point where the diet can be as liberal as possible, with potentially occasional times of needing to pull back and restrict a little bit more. But the goal is to have as liberal a diet as possible. And this is so important for a few reasons. And one of them is that restriction of some of these foods, as I mentioned, a lot of them are fruits and vegetables, healthy foods, can lead to depletion of some of the good gut microbes. And I'll go into that in a moment. But first, I want to share with you some of the research on how on the low FODMAP diet. And pooled studies show that it's effective in up to 80% of patients with IBS. So that's better than some of our medications that we have for IBS. The number needed to treat, which refers to how many patients do you need to treat in order to get a positive response, is 5. You want the lower the better. And so 5, again, is excellent. That actually beats out a lot of our best medications for IBS. Global symptoms tend to improve, as well as specific bothersome symptoms, such as bloating, flatulence, and diarrhea. There have also been some analyses that have studied the low FODMAP diet versus other diets, and the low FODMAP diet seems to be the superior diet for IBS. So once again, going back to the AGA recommendations, dietary modification is a first-line intervention for IBS. Now, the low FODMAP diet isn't perfect. First of all, it's very restrictive, particularly if done incorrectly. If you search for the low FODMAP diet online, you'll find lists, such as one that I've included here, of hundreds of foods that one has to avoid. And unfortunately, what happens too often is that patients will find this online and will just begin to follow it and have this indefinite period of a very restrictive diet, which can lead to micronutrient deficiencies and can also lead to a type of eating disorder called avoidant restrictive food intake disorder, which is an anxiety disorder around food triggering GI symptoms. It's something that I see on a weekly basis because 40% of patients with disorders of gut-brain interaction actually have avoidant restrictive food intake disorder, ARFID. And so highly restrictive diets can sometimes contribute to disorders like ARFID. And so when done incorrectly, it's an overly restrictive diet. Because of this, it can only be done in close supervision by a registered dietitian. This really isn't something that you can hand a patient this paper to and say, avoid these things, eat these things, good luck. It's a 3-phase systematic diet, and a trained gastrointestinal registered dietitian is really the only one who can guide somebody through the 3 phases of the diet. There are also nuances of which foods to avoid and which ones to include. And I say that because I've learned this from my registered dietitian colleagues, that when you look at these lists, sometimes they'll say, a particular food needs to be avoided because it's high FODMAP. But perhaps if you cook it in a different way, or perhaps the stem of it is low FODMAP, but the flour of it is high FODMAP, there are nuances which can't be captured in a lot of these lists that you find online and can only be elucidated through having an expert guide you through it. Now, one potential way around this is now we have apps, phone-based apps, that can help guide someone through the low FODMAP diet. So that's something that's increasingly being explored and I think has a lot of promise. The last pitfall to talk about is what I alluded to earlier, a reduction in beneficial bacteria. A lot of these high FODMAP foods are prebiotics and are very healthy foods for the microbiome and the body. And so if we restrict those, we're restricting a lot of fruits and vegetables, the microbiome diversity does go down. We lose good bacteria like bifidobacteria in particular, and other butyrate and short chain fatty acid producers. These are bugs that produce these powerfully anti-inflammatory short chain fatty acids that have numerous health benefits, not just from the gastrointestinal standpoint, but systemically. And so perpetually avoiding these foods can lead to these changes in the microbiome and the metabolome, which may be rather detrimental. Now, there may be some ways around these. One is we know that by doing the diet correctly and personalizing, reintroducing the foods, liberalizing the diet does restore the bifidobacterium levels. We also know that perhaps there have been a few studies showing that prebiotic and probiotic supplementation may also prevent the decrease in bifidobacteria levels on a low FODMAP diet. So there may be some ways around these. What's interesting coming out of some more recent research is that not all FODMAPs are created equal. It appears that certain FODMAP foods disproportionately cause symptoms for people. And it turns out that in particular, fructans, galactans, mannitol, and lactose are the most likely to cause IBS symptoms in people with IBS and visceral hypersensitivity. So there's an idea of some people are calling it a FODMAP light diet, where you recommend reducing or eliminating only those most bothersome of FODMAPs so as not to impose such a restricted diet. And this is actually something I do fairly regularly in my practice in patients, particularly with milder symptoms who link their symptoms to diet. I'll often recommend a limited trial of removing dairy and wheat from the diet and seeing if that helps the symptoms. And in my experience, I've had very good experience with just removing those two for either a temporary period of time or a longer period of time, that can really help a lot of patients' symptoms. Let's move on to the Mediterranean diet. So the Mediterranean diet is one of the most studied diets in general. So not just in GI. It's characterized as a predominantly plant-based diet, rich in many different fruits, vegetables, nuts, seeds, legumes, healthy fats such as olive oil, limited fish, and a restriction of animal products, processed foods, sugars. And it's been consistently linked with numerous health benefits. Again, not just from the GI standpoint, but systemically. We know from studies in GI that it's a very beneficial diet for the microbiome. It is associated with improved microbiome diversity, composition, and function, and even reduces inflammation in the gastrointestinal tract. So it's a very healthy diet for the microbiome. But what about an IBS? There haven't been too many studies in IBS, a few small studies, in this one only 29 patients, but the Mediterranean diet was found to improve IBS symptoms as well as psychological symptoms, anxiety and depression, which are very common in IBS, and was found to be well tolerated. Patients liked being on the Mediterranean diet. Another study compared a low FODMAP diet, a gluten-free diet, and a balanced diet. But if you read the paper, you'll see that the balanced diet was actually a Mediterranean diet. And this was a study in IBS patients. And it found that the Mediterranean diet was just as effective as the low FODMAP diet in improving symptoms, but it was preferred over the other diets. Patients preferred to be on the Mediterranean diet than the low FODMAP diet. No surprise. Again, the low FODMAP diet, very restrictive, very involved to do. A more recent study looked at trying to combine the two. Could we perhaps make a Mediterranean-style diet that eliminates some of the, or at least reduces some of the high FODMAP triggers? And this symptom-modified Mediterranean diet, as they called it, improved the microbiome, leading to a less inflammatory microbiome. So perhaps this modified Mediterranean diet, removing some, it's like a Mediterranean diet plus a modified low FODMAP diet, can allow the microbiome to still have all of these healthy fruits and vegetables, but reduce some of the high FODMAP foods that trigger symptoms. And we see that there's an improvement in the microbiome and in inflammation. So let's shift gears a little bit here and talk about dietary supplements in IBS. This is something that I get asked about almost on a daily basis. So the first to begin with is fiber. Why might fiber be relevant in IBS? Well, we already talked a little bit by mentioning that a lot of these FODMAP foods are high in fiber, and yet they trigger symptoms of IBS. We also know that the healthiest diets, such as the Mediterranean diet, are plant-based, filled with these diverse fibers, fruits, vegetables, nuts, seeds, legumes, etc. So how do we reconcile these two? Well, the way that we reconcile it is that fiber is an enormous umbrella term. There are so many different types of fiber, and based on their physical and chemical properties, some of these are beneficial for IBS, while others, such as the very gas-generating ones, can actually be detrimental and worsen IBS symptoms. So which types of fibers should we be recommending? Well, if you look at the professional gastroenterology societies, I've included two of the American societies, the British Society and the Canadian Society. There is uniformity here in the recommendation that fiber should be recommended, and particularly soluble fiber. Soluble fiber is beneficial for IBS, whereas insoluble fibers can worsen IBS symptoms. And so this is an evidence-based guideline recommendation here that soluble fibers are beneficial in IBS. There have been multiple systematic reviews and meta-analyses that have demonstrated that fiber, and in particular soluble fiber, is beneficial for IBS. And I've highlighted in particular here the numbers needed to treat. And again, we have fairly low numbers here, 5.8, 7. Easy intervention to do either from the diet, foods high in soluble fibers, or from taking a fiber supplement that's high in particularly soluble fibers. Now, what about prebiotics? This is something that comes up all the time. So a prebiotic is defined as a substrate that is selectively utilized by host microorganisms, i.e. the gut microbes, conferring a health benefit. Prebiotic supplements have been studied in this meta-analysis and find that there is an increase in the good bacteria. So the prebiotics are doing something, but there's not really an effect on global IBS symptoms or specific symptoms such as abdominal pain, bloating, or flatulence. And why might this be? It seems, fiber is helpful, we know foods are helpful, so why are prebiotic supplements on their own? My hypothesis for this has to do with the fact that a lot of prebiotic supplements are taking one substance, one fiber, for instance, whereas the gut microbiome being such a complex ecosystem, benefits from diversity. And so that's why we know that dietary approaches with diverse fibers are going to be more effective than a prebiotic supplement that includes one particular compound. And so I actually do not recommend that my patients take prebiotic supplements. I recommend that they get their prebiotics exclusively from the diet. There's more diversity and more of an effect there, and we know that it has a better effect on IBS symptoms. So fiber in general, soluble, helps IBS symptoms. There's a number needed to treat of about 6, very safe and well tolerated. And this is a guideline recommendation from all of the professional societies. Peppermint oil is a very interesting compound. It's usually a hybrid of spearmint and watermint. L-menthol is one of the active ingredients. And there are numerous proposed mechanisms of action of why it works in the GI tract. There's a calcium channel antagonism effect. There's activation of the endogenous opioid system. And there are some purported anti-inflammatory and antimicrobial effects. Peppermint oil is one of the most common supplements that patients take on their own, whether directed by a healthcare provider or not. The ACG recommends peppermint oil. The British Society recommends peppermint oil, and the Canadian Society. So we have guidelines recommending peppermint oil. In this meta-analysis here, peppermint oil was superior to placebo for global IBS symptoms, superior for improving abdominal pain. It's important to note here, though, that just because something is natural doesn't necessarily mean that it's completely harmless. Adverse events or side effects were much higher in the peppermint oil group, with a number needed to harm of about 15. This slide here includes some of the formulations of peppermint oil that were included in the meta-analysis. Now, there's a lot of controversy if you look deeper into the peppermint oil literature, because there's a lot of bias, which is true in a lot of supplement studies. There's also heterogeneity into where the supplements are being released. There's a small intestinal formulation where you bypass the stomach and have the peppermint oil released in the small intestine. And there's some evidence that perhaps that's a superior mode of delivery. But if you look at all the studies included in the meta-analysis, there's very low quality of evidence. There's a lot of heterogeneity in methodologies. Adverse events are very common. And then there's also because of all of this, there may actually be no effect of peppermint oil. Some studies have looked to compare it with other treatments and find that peppermint oil, it beats out fiber and some medications even in being the best treatment for IBS, and that it's a very cost-effective option. Now, could this all be a placebo effect? Now, why might this be? IBS, being a disorder of gut-brain interaction, is very influenced by psychological factors. In fact, there's a strong placebo effect in IBS. And this study looked to address that. It was a study out of a lab at Harvard that was studying whether the effect of peppermint oil is placebo. They gave people peppermint oil, they gave them placebo, and in both groups, there was a very dramatic effect on improving IBS symptoms. But there was no difference between the placebo group and the IBS group, the placebo group and the peppermint oil group, rather, suggesting that perhaps the peppermint oil effect was driven by placebo. Additionally, the peppermint oil group had a lot of side effects, including heartburn, reflux, regurgitation, and belching, with a very low number needed to treat of 6. So this is concerning that perhaps the effect is driven by placebo and you have a lot of side effects. So overall, we know that peppermint oil does improve IBS symptoms. There's a low number needed to treat. The guidelines recommend it, but the effect might be mediated by placebo, and there are considerable side effects. Now, I tell patients, if this is something that helps you, doesn't matter whether it's placebo or not. If it helps you, it helps you. But if you find that you're having these adverse events and they're intolerable, then it's something we want to discontinue. Probiotics is something that is near and dear to my heart, and I've spent a lot of time thinking about and researching including in my professional time at the Mayo Clinic. And it's something that I could talk about all day, but I'll just go briefly through the literature in IBS. So probiotics are live microorganisms that, when given in adequate amounts, confer a health benefit. There are many proposed mechanisms of actions for why probiotics might be helpful. And in IBS specifically, IBS features dysbiosis or abnormalities of the gut microbiota. And so microbiome interventions such as probiotics may be helpful. So what do the guidelines say? This is the first time where we see disagreement. So the ACG recommends against. The AGA recommends against unless you're in a clinical trial. What do the folks in the UK say? Well, they say maybe probiotics are helpful, but we can't tell you which. In Canada, however, they say, yeah, probiotics are helpful. We should recommend them. So what's the confusion here? Well, the confusion has to do to some of the reasons that there was heterogeneity and methodological limitations in the peppermint oil literature and in a lot of supplement literature. But we're now at the point where we have robust clinical trials and even meta-analyses. So I've highlighted one meta-analysis from last year here that looked to see which particular strains are helpful in IBS, as opposed to classifying probiotics in general. Since each is so different, we need to study strain specificity. And so this review looked at 82 randomized control trials over 10,000 patients and found that specific probiotics are helpful in improving global symptoms, improving symptoms scores. They also looked to see at IBS phenotypes, and they found that diarrhea predominant IBS, IBS-D, responds better to probiotics than IBS-C, and there are specific probiotics that were listed. Similarly, looking at specific symptoms, abdominal pain had certain strains that were effective and certain that were not. Bloating and distension. Probiotics were safe. The adverse events were not higher than placebo, unlike in the peppermint oil trials. And so overall, global symptoms were improved by certain probiotics. Abdominal pain was improved, bloating and distension, symptom scores, and IBS-D responded better than IBS-C. Finally, probiotics were safe. I've summarized the strains for each here. Now, this literature does have limitations, again, because the supplement industry is not regulated. There's low quality of evidence. There's a lot of bias, heterogeneity, short trial duration. Some studies still combine strains, which makes it very challenging to interpret. But on the whole, there seems to be a positive effect as found in the meta-analysis. I also want to include here, as I alluded to earlier, that probiotics might actually enhance the effects of a low FODMAP diet. In one study, the D-Simone formulation prevented that decrease in the bifidobacteria that we know is caused by a low FODMAP diet. In another study, a multi-strain probiotic, while on a low FODMAP diet, improved the microbiome diversity and composition. That correlated with improved IBS symptoms. And finally, a more recent study found that a Bacillus coagulans probiotic, while on a low FODMAP diet, led to superior resolution of IBS symptoms than a low FODMAP diet alone. So overall, probiotics as a class, especially combination probiotics, improve IBS symptoms in general and specific IBS symptoms. There seems to be a stronger effect in IBS-D than IBS-C. Strain specificity is very important, and we now can say with confidence which specific strains are helpful in IBS. We have to be cautious that there's low quality evidence and that there's inconsistency in the guidelines. Some of the guidelines, including the American societies, specifically recommend against probiotics. Vitamin D is a common supplement that many people take even outside of gastrointestinal reasons. We know that IBS is associated with vitamin D deficiency and that vitamin D plays a role in maintenance of the gastrointestinal system. And so this is perhaps an intervention that might be helpful. Well, in meta-analyses of vitamin D supplementation, it turns out that vitamin D is not consistently helpful. This one meta-analysis in particular found on the first pass that vitamin D may help IBS symptoms, but when you actually control for the highest quality studies, then there's no improvement in IBS symptoms and no improvement in quality of life. So overall, vitamin D is not something that we should confidently recommend to improve IBS symptoms, and it's not something that's even mentioned in the guidelines. Glutamine is something that's interesting that certain patients have asked about. The reason that glutamine might be helpful is that IBS, particularly in post-infectious IBS and in IBS-D, is associated with increased intestinal permeability, or again, this leaky gut physiology. And glutamine plays an important role in maintaining the integrity of the gut epithelial barrier. We know that glutamine supplementation can reduce that intestinal permeability. In one study of IBS-D patients who had a prior infection of the GI tract and had documented increased intestinal permeability, glutamine was very impressively helpful in normalizing intestinal permeability, improving IBS symptoms, and the IBS symptom improvement correlated with the normalization of the intestinal permeability. Another study found that glutamine may enhance the efficacy of a low FODMAP diet. A meta-analysis from the traditional Chinese medicine literature looking at a particular compound that includes glutamine found that there was no difference in improvement in IBS-D with the glutamine compound versus other conventional approaches, meaning that it might be just as good as some of the other therapies that we have to date. So overall, we have only a couple small studies, but some which are promising. It's not yet included in the guidelines, but I will say that in patients where there really is a clear evidence that they have post-infectious IBS, that I do sometimes recommend glutamine in those patients. Finally, the last intervention I want to talk about is digestive enzymes. This encompasses a large category that patients frequently ask about, and there are actually very few studies in IBS. There's some research on alpha-galactosidase, which breaks down some of the FODMAP foods, particularly galacto-oligosaccharides, and there's been conflicting evidence. Some studies find that it can help IBS symptoms, but other studies have found that it doesn't make any difference in IBS symptoms. There was one small study that found that pancreatic enzymes can help patients with IBS diarrhea who have diarrhea after meals. But there really isn't much research apart from that. So as much as there's interest in digestive enzymes, there really aren't studies. In the studies that are there, we have to think about mimics of IBS, such as carbohydrate malabsorption and exocrine pancreatic insufficiency, that we treat with digestive enzymes. Those are the treatments for those conditions. So perhaps these patients in these trials actually had those conditions and benefited from the appropriate treatment. And so because of all of this, digestive enzymes are not something that are routinely recommended for patients with IBS. Again, with the exception being, if we identify that they have a condition that can be treated with it, but for run-of-the-mill IBS, it's not. Now, this is a good segue here into IBS mimics. So a recent article came out that I really like the title of. It was called "Getting the BS Out of IBS," and it specifically focused on IBS-D. And the reason for this is that historically, we've relied on the Rome 4 criteria, saying, hey, if you have these symptoms, you have IBS. But there's increasing research that a lot of cases of IBS, particularly diarrhea, up to 2/3 of these cases may actually be attributable to another disorder. And I use the term organic here, not that I endorse that there's a distinction between organic and functional, as there has been historically. It's far more complex than that. But this is just to say that due to a concrete disorder that we can identify on lab testing or endoscopy or something, 2/3 of the time, it might actually be something else. So what might these things be? This is not a comprehensive list here. This is just a few of the mimics of IBS: celiac disease, IBD, microscopic colitis, eosinophilic gastrointestinal disorders, bile acid malabsorption, small intestinal bacterial overgrowth, disaccharidase deficiency, so these carbohydrate malabsorption syndromes where you don't have the enzymes to break down these particular sugars, neuroendocrine tumors, pancreatic insufficiency, alpha-gal syndrome, which is an allergy to meat products caused after a tick bite, mast cell disorders like mast cell activation syndrome, endometriosis, pelvic floor dysfunction / dyssynergic defecation, various medications and supplements. So again, this is not an exhaustive list, but in my practice, particularly where I'm seeing people for second, third, fourth opinions, and particularly at Mayo, where I have the great fortune of having access to testing that a lot of other centers don't have, I test for a lot of these conditions specifically in patients with presumptive diagnoses of IBS diarrhea to ensure that we're not dealing with something else that's diagnosable and treatable. So I really try to do my due diligence in ruling out these other things before giving that diagnosis so that I know how best to treat the patient. And as I mentioned before, if you've seen one patient with IBS, you've seen one patient with IBS. Some people may have different contributors. This is a great figure from a paper by Dr. Camilleri, who is one of the leading experts in the field of gastrointestinal motility, who's here at Mayo. And it talks about, again, shifting our focus to the unique pathophysiologic contributors in each patient's experience of IBS so that we can give them the right treatment. For instance, if their constipation is due to pelvic floor dysfunction, they don't need more laxatives. They need pelvic floor therapy with biofeedback. And if somebody has bacterial overgrowth, we need to treat the dysbiosis there and treat the overgrowth through antibiotics, probiotics, diet, etc. Visceral hypersensitivity, if that's what's driving the symptoms, we need to target those overly sensitive nerves. So this is really the future of IBS, is identifying the unique contributors, ruling out these mimics, and figuring out what a unique person's IBS experience is being caused by and targeting their treatments. In other words, personalized medicine. So to conclude, IBS is a very common disorder of gut-brain interaction. Diet is one of the most common triggers, with specific food triggers being FODMAP foods and high histamine foods. Specific diets are effective, including the low FODMAP diet and the Mediterranean diet. Various supplements can improve IBS symptoms, such as fiber, probiotics, and peppermint oil. And then we always have to be on the lookout for IBS mimics, especially in patients who are not responding to therapy. And we need to investigate those in order to come up with the best personalized treatments for the patients in front of us. So with that, I'll conclude. I'll open it up to any questions. I have my contact information here. You're always certainly free to reach out with any questions. I love talking about these things. And so please, I'll turn the floor back to you, Lindsay, and I'm happy to stick around for as much time as we have for questions.
Thank you so much for that brilliant presentation, Dr. Damianos. We had so many comments coming in of people who are just appreciative. Even our production crew is really excited. They want a copy of this. And so just some really, really good insights there that I think are probably not available elsewhere. So if you've joined us, midway through this presentation or something, we're speaking with Dr. Damianos, who is a gastroenterologist and hepatologist from the Mayo Clinic. And he just gave us an incredible overview about irritable bowel syndrome. And April is actually Irritable Bowel Syndrome Awareness Month. And I'm so thankful for that presentation and all that you were able to share there. So if you do leave a comment, or if you have a question for Dr. Damianos, feel free to just leave those in the comment section. We'll be bringing those up. For Dr. Damianos, he's given generously of his time to be here today, and these sessions are not sponsored, and so I want to make it very clear that he's giving his time and his expertise to us today, and we're greatly appreciative of that. Just as the questions come in, if you do leave a comment or a question, you'll also be entered into win one copy of the Gut Logic book here, which is an evidence-based resource written by Graham McKenzie, who is also with us. And we will be giving that away at the end of the session. Dr. Damianos, we actually had Dr. Andrea Furlan from the University of Toronto join us on Instagram for this session. And she had a few questions about IBS and fibromyalgia. She has a lot of patients with fibromyalgia.
Yeah.
And she's wondering if there's a link between IBS and fibromyalgia. And then she also wondered if exercise is ever possibly beneficial in these cases?
So this is a fantastic question. So is there a link here between IBS and fibromyalgia? And the answer is yes. And the reason for this is shared pathophysiology, particularly visceral hypersensitivity and central sensitization. So IBS is characterized by those abnormalities in the gut-brain axis. And the gut and the brain are connected by the enteric nervous system. And so problems in one are going to affect the other. IBS is very frequently comorbid with other chronic pain syndromes. Fibromyalgia is a disorder of central sensitization. That's really the underlying driving pathophysiology of fibromyalgia. And this same central sensitization in conjunction with visceral hypersensitivity is seen in IBS. So there's a very strong link there. Chronic fatigue syndrome being another one, endometriosis, chronic migraines, a lot of these chronic pain syndromes are found in people with IBS because of that shared biological underpinning of the central sensitization. And so that leads into the second part of the question too, is exercise beneficial in IBS? And the answer to that is yes too. I focus my talk today on dietary interventions and dietary supplements, but there's a whole host of other treatments that we could talk about: lifestyle changes, pharmacologic interventions, gut-directed hypnotherapy, gut-directed cognitive behavioral therapy. There's a whole host of other treatments, but exercise has been linked in many, many studies to interventional studies, including in an improvement in IBS symptoms. So absolutely.
Thank you very much for that. I know Dr. Furlan was really interested in your presentation. She had to go, but she's planning to come back and rewatch the rest of this, so she'll be really appreciative of that. Graham, did you have any comments or questions for Dr. Damianos?
Oh, I have like 1,000 questions. It was such a good talk. Really, it was to have that much condensed information in an hour is rare, and such good quality information. If I could pick out one question, Dr. Damianos, you spoke about leaky gut, and Lindsay and I have discussed this issue in the past. And so leaky gut is something that I think we can agree is probably extrapolated on a little bit. Could you tell us, like, what is it that we know and what we know happens and what we know doesn't happen from increased intestinal permeability? Does it actually cause disease?
Yeah, that's a really great question. It's one that a lot of really smart people are thinking about and researching right now. In particular, to bring back Dr. Camilleri here at Mayo, he's pioneered a lot of research on intestinal permeability. And he was recently featured in a nice National Geographic article on leaky gut physiology. And so I encourage you all to look up this National Geographic article where he and some other experts answered these exact questions. But the problem with the idea of leaky gut is the so-called leaky gut syndrome. And so this is essentially an idea that increased intestinal permeability is attributable to, or is the cause of, chronic non-specific symptoms across organ systems. And it's a way that a lot of pseudoscientists can target people with chronic illnesses to sell a supplement or a protocol or something by saying, oh, all of your symptoms are attributable to, this increased intestinal permeability. We know that that's not true. We do know that the physiology is real of increased intestinal permeability, allowing for the leakage or the seepage of dietary antigens, bacterial toxins, etc., into the bloodstream and causing immune activation. But there's a very strong bidirectional relationship, and we don't know all of the consequences of it. In fact, there are physiologic times when the permeability is increased, exercise being one of those. Strenuous exercise causes leaky gut physiology. Well, all of our best athletes internationally are not plagued by chronic illnesses because of this, because they're more commonly in this leaky gut state than the rest of us. So it's far more complicated than just, is there increased permeability or not? And Dr. Camilleri has actually been developing a test of intestinal permeability to help address some of these questions. And part of the research that I'm involved in at Mayo with him includes using this test to see the effects of increased intestinal permeability. So in and of itself, we can't use it as the scapegoat that it's causing various disease states. There is not evidence to say that. Is it an important contributor to pathophysiology for certain disease states? Yes, that is true. So it's much more nuanced than is often given credit for.
Yeah, good explanation. I think that's we'll be talking about that in sessions coming up, and it was good to have a good introduction to that.
I also wanted to mention, you talked a little bit about the gut-brain axis during your presentation, and you were also talking about gluten. And we know that there is a difference between celiac disease and gluten sensitivity, and that gluten sensitivity is a very real thing. A lot of people who seem to have a sensitivity to gluten, even though it's not necessarily confirmed clinically, complain also about brain fog.
Mhm.
So do you know what the mechanism is there?
Yeah, it's a very good question, and one that does come up frequently. So the first part to tackle is what exactly does gluten sensitivity mean? We know there's celiac disease, which is an autoimmune disorder from proteins in wheat, where the immune system causes an attack on the small bowel in reaction to the ingestion of those in people who are genetically susceptible. But then there's this other large category of patients who do not have celiac disease, but who consistently have gluten or at least wheat that triggers their gastrointestinal symptoms. And so for a long time, there's been sort of investigation of, is there this entity non-celiac gluten sensitivity, or is this attributable to something like IBS? And the best way to test that is by using blinded placebo-controlled trials of gluten, where they have people with self-reported gluten sensitivity, and you give half of them gluten in a capsule and you give half of them a placebo in a capsule. And it turns out that in those studies, consistently, patients cannot tell the difference between the gluten and the placebo. So there's a huge nocebo effect there, the opposite of the placebo effect, where patients with gluten sensitivity, when they think they're getting gluten, they report gastrointestinal symptoms. This is due to dysfunction of the gut-brain axis, not due to a chemical effect of gluten. Similarly, in other studies that have used similar methodologies, we know that it's not the gluten, but it's the fructan component. It's the FODMAP component. And so a lot of these patients actually have visceral hypersensitivity, which is seen in IBS and other disorders of gut-brain interaction like functional dyspepsia, not gluten sensitivity, non-celiac gluten sensitivity. So in my experience, most of these patients actually have IBS, not this some entity that's related specifically to gluten. Now, why might they have brain fog? Brain fog is one of the most common extraintestinal symptoms of IBS and a lot of other chronic pain syndromes. So again, fibromyalgia, chronic fatigue syndrome, brain fog is a key symptom that patients report. Some of this may be due to the microbiome. There's some evidence that brain fog and bacterial overgrowth are linked. And IBS has a strong relationship to small intestinal bacterial overgrowth. It's an IBS mimic, and there are some people who have IBS related to small intestinal bacterial overgrowth. And so I think that brain fog plays a role there. And dysbiosis is certainly one of the links that I think contributes to the brain fog. And then again, that central sensitivity that we see in IBS and fibromyalgia also contributes to the brain fog. So a couple different mechanisms.
Thank you very much for that explanation. That makes a lot of sense. And I know that on this channel, we do have people who have long COVID as well, who are watching, and they also complain or note brain fog as well. And I know you actually have an excellent presentation that you were part of with AE Pro Bio. People can go to aeprobio.com. You did a whole presentation on the gut microbiome and COVID-19 infection, where I think you explain this in detail, if I'm not mistaken.
Yes,
Mhm.
absolutely.
Mhm. You mentioned SIBO. If anyone has any questions, we had a couple questions come in. We're just waiting to see if there's any more questions. So any questions for Dr. Damianos, feel free to leave those in the comments. You mentioned SIBO, and we hear about these SIBO breath tests and the lack of efficacy or lack of evidence for them. What are your thoughts on these?
That's a whole other talk. I think we need a whole other hour to talk about
Fair
SIBO.
enough. Fair enough.
But I can sort of give you the short version of my answer, and it's something that I think about a lot because part of my research here at Mayo includes research on SIBO. It's a very controversial entity for a few reasons. Number one being that the diagnosis of SIBO depends purely on the number of bacteria, an overgrowth of bacteria. And so that doesn't actually have anything to say about the type of bacteria. All of the testing for SIBO is also fraught with limitations. And so technically the gold standard is aspirate obtained during endoscopy. And this is actually something that I do frequently with my patients. So you do an upper endoscopy and you go into the duodenum or even in the jejunum and take an aspirate of the fluids in there and culture them out. But you can get false positives there from contamination from the oral flora and from the flora more proximally in the gut. So there are problems with that. It's also expensive and invasive to do. And then you have these breath tests, which are indirect measures of fermentation and bacterial overgrowth. And there are many limitations to that too, with both false positives and false negatives impacted by many different things, most importantly, oral-cecal transit time. So a lot of patients with IBS have fast transit, particularly in the IBS diarrhea patients. They have fast transit. So positive breath tests may actually be due to normal fermentation in the colon as opposed to in the small intestine. So it's very difficult to interpret these tests correctly. The recommendations currently for SIBO testing is not testing indiscriminately, but testing in people who have risk factors for bacterial overgrowth. And one of the main risk factors is small intestinal dysmotility, such as we see in disorders like scleroderma. We know that patients who have scleroderma and who have had abdominal surgeries, that's another one, who may have had nerve damage in their gut. Diabetes is another one. So in these patients who present with chronic gastrointestinal symptoms, the pretest probability is higher, and so we can use these tests. But you're absolutely right. There are limitations to all of our testing, and some people even challenge the notion that what we call SIBO is attributable to symptoms. There are people who test positive for SIBO but who don't have symptoms. And I think that my opinion is that the type of bacteria are more important than the number of bacteria. And some of the research coming out of now Cedars-Sinai, where they do a lot of research on SIBO, is looking to identify what are actually the causative bacteria that are triggering gastrointestinal symptoms. So in my mind, the problem is more dysbiosis than SIBO, but there's a lot of evolution. So definitely keep your eyes on that space. There's a lot of controversy, a lot of growth. And keep your eye out for some of the papers that I'll be publishing from Mayo on SIBO from our extensive experience and database.
Yeah, we'll definitely do that. And that's something that we've been mentioning in these sessions is that a lot of this is new science and it's evolving and it is even controversial. And you can see that different scientists sometimes really strongly disagree in certain areas.
Exactly.
And so we're trying to bring the best evidence here, right? And you're really helping us do that. So we do have some questions that have come in from some of the viewers. A lot of questions about diet. I eat yogurt with a freshly ground mix of flaxseed and half chia seed. How about 2 tablespoons and yogurt? Is this providing any benefit or am I wasting my money? So I don't know if this is necessarily about IBS, but just a more general question about, I guess, GI health and whether this is beneficial. I guess it really depends also what kind of yogurt that is. and how much sugar?
Yeah, I think a lot of people, one of the most common questions that I get from, not just patients, but even, friends and family members is, what's the best diet for gastrointestinal health? And that's sometimes a little bit hard to answer because everyone's a little bit different. And depending on if you have a gastrointestinal illness, then you might need to follow a certain diet. Again, like if you have celiac disease, you have to avoid gluten. Or, if you have IBS and you're very sensitive to FODMAPs, then you're not going to feel well if I tell you, focus on fruits and vegetables. But my general answer to people, especially if they're otherwise healthy and don't have any gastrointestinal illnesses, is that it's a predominantly plant-based diet with diverse fruits, vegetables, nuts, seeds, legumes that emphasizes those things and minimizes animal products and processed foods, refined sugars. And I kind of call it grandmother's advice of healthy eating. I think there's a lot of pseudoscience in the diet world, and there's so many people, trying to sell supplements and protocols and things. But at the end of the day, it's really the common sense recommendations that have the most evidence of get your fruits and vegetables, eat real food, and minimize processed foods and artificial sweeteners and things like that. So that's what I recommend for the vast majority of people is eat real food, eat lots of different kinds of plants, and that's going to put your gut in a good place for most people.
And we did cover a little bit of that as well in our last session. So if you're interested in hearing more, Dr. Damianos did mention fiber and insoluble versus soluble fiber, right? And we covered that a little bit in our last session as well. So if you want to know more about that, you can definitely go back to session 2. Another question coming in here from Manjeet Hansra: are stool tests like Viome or GymMap accurate for what's happening chronically in the body, or are they just an indicator of acute issues?
So that is a phenomenal question, and is also one that comes up from patients a lot, because there are so many of these direct to consumer tests that patients can order themselves from these companies and spend hundreds of dollars, if not more, on these tests that purport to map your microbiome. I want to be very clear that there's no evidence that these provide anything clinically meaningful at this time. There are a few reasons for this. The first reason comes from the fact that what we call the microbiome is not just one unchanging entity. First of all, the composition of the microbiota is different at each part of the gastrointestinal tract. So our mouth, our esophagus, our stomach, each portion of the small intestine, and each portion of the colon. And so what are you actually studying when you're taking these stool tests? Well, most of that is actually colonic flora, but particularly that's coming from the stool. So this also touches on the difference between the stool microbiome and the luminal microbiome. What's coming out in stool is not what is associated with the mucosa. Finally, the small intestinal microbiome might be more important than the colonic microbiome because the work of digestion occurs in the small intestine. The colon functions to reabsorb water. It's the small intestine that absorbs our nutrients and does the work of digestion. So for all of these reasons, and another important one being we don't know what a normal microbiome is, and the microbiome changes from so many different things: diet, location, geography, sleep, stress. We know even from studies on sleep and the circadian rhythm that the gut microbiome follows a circadian rhythm. And so it's constantly changing. For all these reasons, we can't get any clinically relevant information from these stool studies that say, oh, you have high numbers of this and low numbers of this. I think perhaps in the future we will be there, and I would hope that it would be small intestinal microbiome sampling that probably I would think has the most promise. But right now, we really cannot gain anything clinically relevant from these direct-to-consumer tests, and they're not something that any of the major academic institutions are using in clinical diagnostics.
That was a really great question and just really important to point out because so many of these direct to consumer tests are going to increase. The number is going to only increase, and I don't know if the regulations will be able to keep up with that, right? So it's really important to point that out. And very interesting about the small intestine as well, because up until this point we've been talking about a lot about in the previous sessions about the large intestine and the importance of fiber and that kind of thing, right? But it is true, the small intestine, that's where the majority of your nutrients are absorbed. And so that function is just so essential. So thank you for pointing that out. Michelle Blake says, I wonder if Dr. Damianos has any recommendations on which digestive enzymes to take. Yeah, there are quite a few different ones out there. I guess it probably depends on the person, the condition. But do you care to comment on that one, Dr. Damianos?
Yeah, you're exactly right. It depends on what you need them for. In IBS, not recommended. Again, we there's no data that suggests that digestive enzymes are helpful in patients with IBS. There are conditions where they are helpful, and so pancreatic exocrine insufficiency is one of those conditions. And so I spend a lot of time in our pancreas clinic, and we have a lot of patients who have chronic pancreatitis, and they've had scarring and inflammation in their pancreas for years that's burned out the capacity of the pancreas to produce pancreatic enzymes. And so those patients need pancreatic enzyme replacement therapy, or PERT, usually with Creon. And so in patients who we know have pancreatic insufficiency, they benefit from pancreatic enzyme replacement therapy. And again, that's something you can easily test for and supplement accordingly. Similarly, in certain carbohydrate malabsorption syndromes, digestive enzymes can be helpful, supplying the enzyme that's lacking. And so lactose intolerance is the most common carbohydrate intolerance. The tricky part here is that you probably know many people who are lactose intolerant, since lactase non-persistence is the norm, not the exception. You probably know a lot of people who have taken lactase, but who say that it's not helpful for them. Well, the reason for that is that not everyone who has lactose intolerance has lactose malabsorption. Some of the effect of lactose intolerance is actually from the FODMAP effect. And so you might have enough of the enzyme, but you can't tolerate dairy because of the FODMAP effect of it. And so in people who purely have lactose malabsorption because they lack the enzyme, but they don't have visceral hypersensitivity, lactase would be helpful for them. But if they have the enzyme or don't have the enzyme, but have IBS and visceral hypersensitivity, then the enzyme isn't going to be helpful because that's not targeting the problem. So this is all to say, again, of trying to identify the unique contributors so that we can give people personalized therapy recommendations.
Absolutely. And I just noticed at the back of Graham's book here, Gut Logic, he has a gut health journal for people to write down, what is their food and beverage intake, your physical activity and exercise. When people are coming to see someone like you, Dr. Damianos, is it helpful that they have some things documented? Or like, what are the things that you would really appreciate your patients maybe being more prepared for when they go in to talk to someone like you in order to have the most efficient, I guess, appointment?
Oh, what a great question. It definitely is helpful. And I do encourage my patients to keep food diaries when they note that certain foods are bothersome, because by taking that detailed history, you can unearth a lot of what the problem is. Sometimes people will come in and say, all foods bother me. If I eat anything at all, then I have a lot of symptoms. But if you really have them documented, you can start to tease apart patterns and say, what type of day the symptoms are coming, when in relation to eating. So, is this a stomach problem? Is this a small bowel problem? Is this a colon problem? You can really learn a lot from symptom diaries. And so keeping a food diary is helpful. There are also standardized bowel diaries out there that are validated in the literature that help people track their chronic digestive symptoms. That can be very helpful for working up chronic gastrointestinal issues. And I'll tell you that I use this all the time. One classic example is in patients presenting with diarrhea. One of the most common causes of diarrhea that I see is constipation, specifically the overflow phenomenon. It's people typically with pelvic floor dysfunction or dyssynergic defecation who have developed rectal hyposensitivity. They don't feel when their rectum is filled with stool, and their rectum is trying to push stuff out, and so it's squeezing out all this liquid stool, and they think that they're having diarrhea when really they're completely backed up, and the system is just completely poorly wired because of the pelvic floor dysfunction and the brain gut dysfunction. And those types of bowel diaries can be very helpful in figuring out, we're actually dealing with constipation and not with diarrhea. So history can really teach you a lot of things when working up chronic gastrointestinal disorders.
Yeah, and I think in the healthcare systems today, I'm not sure what it's like in the United States, but physicians are in such high demand, and there's very little time during these consults. And so the patient that is prepared and able to give their physician or their healthcare provider, that kind of information, I think, and really advocate for themselves in a way that's a little bit more effective, I think is just so important, and I don't think it's ever been as important as it is today. So thank you for sharing that. Graham, did you have any more questions for Dr. Damianos? Do you have time for a couple more questions? I don't.
Of course,
Okay.
Yes, please go ahead.
Because we're going to be here for the next 5 hours. No, I'm just kidding. But Graham, any more comments or questions before we go to a couple more viewer questions?
It's a good point about the diet journal. I'm sure it's just so helpful for somebody like Dr. Damianos. It's almost like when you go in and the only blood pressure reading you ever have is the one in the office, and then you go home for 6 months and you come back and the next one is in 6 months when you get it. If you could bring in that little booklet that has all of the blood pressure, all different times a day, that it's so much more helpful. And I would like to say too that I think the reason why the probiotics got such a bad rap, and even in the medical community, I'm sure, Doctor, you've seen this too, the two things would be, if it meant anything, then we would all have, basically the same microbiota. Everybody's is different, so how could it mean anything? And of course, you explain that. And the other is the prevalence of studies out there that say probiotics don't work for a given medical condition. It's like me saying, go on into my pharmacy because I know there's something in there that works for blood pressure, and you grab a bottle and it doesn't work for the blood pressure. It's because it's for a gout medication. You have to take the right medication, the right probiotic, and the study should really just say, here's the probiotic we used. It didn't work for this condition. And that's a way we can kind of build our knowledge like a puzzle almost.
And the AGA has made a technical review that has done exactly that, to say basically where is there evidence for probiotics and what specific strains. And so that was a very helpful effort, I think, for a lot of gastroenterologists to see, instead of saying, probiotics don't work, period, to say, no, that doesn't quite make sense. Probiotics are indicated in these specific indications and not these other ones. For those of you in the GI world, you may have seen that just a couple months ago, the AGA just came out with an updated review of treatments for inflammatory disorders of the pouch in patients with inflammatory bowel disease who get a surgery and a pouch creation. And probiotics were recommended for the prevention of recurrent pouchitis. And not just probiotics, but specifically the D-Simone formulation. And so I thought that was a really positive step for having our professional society endorse not just probiotics, but a specific strain or formulation as well for a particular indication. So I was very pleased to see that.
Yeah, and dragging a site with the abprobio.com, as a pharmacist, I use that site, weekly when someone's coming in and they're looking for something, because it's done all the work for you, level 1, 2, 3 evidence, Health Canada approved or not, and although it doesn't cover everything, it covers most of the questions we get during the run of a day in a pharmacy. So if she was here, I would say Dragon a great work.
She will be here with us next week for sure. Another question has come in, Dr. Damianos. Marina Smith, is DGL also a good supplement? I've heard that L-glutamine, which you mentioned in your presentation, can cause GI symptoms. What is the best way around this, I guess?
Yeah, so as I mentioned in the talk, there have been a few small studies on glutamine, and the best study was in patients with diarrhea predominant IBS who had a documented post-infectious IBS syndrome and who had documented increased intestinal permeability. So this is a very specific subset of patients. And so as of now, glutamine is not routinely recommended in the management of IBS. I will say in my personal practice, I will only recommend it in patients who very clearly link their symptoms to a GI infection. And that's very few patients who at least I see. Most other people can't pinpoint their symptoms and had other symptoms before, but there are some people I see who say, no, I was totally healthy, totally normal, and then I got food poisoning, and then bam, I've had chronic diarrhea ever since. And in those patients, I treat them like my other IBS patients, but if they're not responding, in those patients, I do sometimes recommend a trial of glutamine, and I've had mixed responses to it. And again, since we don't have much data, it's not something that's routinely recommended. Additionally, since the data is predominantly in these PI IBS patients with intestinal permeability, there's no commercial or there's no clinically available permeability testing as of yet. Again, this is something that we're actively working on in Mayo, and that will be very interesting to see. But again, it's just a patient population that's very narrow and that we can't clearly diagnose. So it's something that if people do have IBSD, they can clearly link it to a prior enteric infection. It's certainly worth a limited trial, but otherwise it's not something that I routinely recommend.
Yeah, Lindsay, also that DGL, I get asked about concussion with, especially if heart disease, high blood pressure, it can lower your potassium levels quite significantly. And it's not something that you should just kind of go and grab and start using on your own. DGL can have, as a supplement, I would put it in the range of the upper level of adverse effects. In fact, I'm doing a talk next week to a physician group on adverse effects, and that's one of the ones that's going to be coming up.
That's a great point. Thank you both for that. And even Dr. Damianos noted in his talk that just because something is natural or available doesn't mean that it is without adverse effects or could not be necessarily harmful, right? These things can have adverse effects, drug interaction.
An example of that I see actually is with magnesium. Because magnesium is a very common supplement, and there's a lot of interest in magnesium for neurologic health and for other reasons. But what's interesting about magnesium, and I'm sure the pharmacists here can speak to this much better than I can, but the bioavailability is very low. In fact, if you look at magnesium oxide, the bioavailability is 5%. So that means 95% is being excreted in the gut, and it functions as an osmotic laxative. That's why magnesium compounds, magnesium salts, are laxatives because of their osmotic laxative effect. They're not absorbed, and so they cause laxation, and in excess, diarrhea. That's why we even use magnesium citrate as part of colonoscopy preps, because it works like that. Now, there are a lot of patients who are presenting with chronic diarrhea, and if they don't tell their doctor that they're taking magnesium supplementation, you may never get to the diagnosis. I've had several patients who I've asked about magnesium, and they've been taking it, and that's what's causing the diarrhea, and stopping it has led to a resolution of their diarrhea. And another interesting tidbit that I learned from one of the senior faculty at Mayo is he had a patient recently who had very high levels of magnesium in the well water. And that's why the patient was having diarrhea. And when they did a trial of not drinking that water, the diarrhea improved. So it's very important to always disclose any over-the-counter supplements that a patient is taking, because it can be relevant for including for adverse effects.
Yeah, magnesium definitely is in the top 5 that I get asked about, I would say, over the last probably 2 years, either for sleep or muscle pain or something like that. So you're always trying to find a form that gets, like glycinate, that might get dissolved a little quicker, but you're right, magnesium oxide probably passes through you like a rock, and you're probably not going to get much absorbed, but it is a popular supplement right now.
Such a good point, and it is such a popular supplement. It seems like everyone wants to be on magnesium, and as pharmacists, we have to field a lot of those questions and issues with it. One last question here before we wrap up. Could Peggy Rue says, could glyphosate be a culprit in these gut disturbances? I'm not sure what the origin of that would be, but
yeah, so that's a good question. So there's a lot of interest into what environmental factors and what dietary factors can impact the gut microbiome and the gut luminal microenvironment in general. And we know that processed foods, ultra-processed foods, and food additives are highly detrimental to gastrointestinal health. There's literature from the inflammatory bowel disease literature. So again, ulcerative colitis and Crohn's disease generally, linking specific food additives to intestinal inflammation. And as part of the recommendations for diet in those conditions, we routinely recommend avoiding food additives because they can worsen gut inflammation. And so similar to that, could pesticides and other chemicals either in the food supply or in the environment impact either the gut microbiome or the integrity of the gut mucosa? And the answer is probably. We don't know for sure, because just like with a lot of nutrition studies, we're relying on a lot of epidemiological evidence, on a lot of kind of basic science, and it's harder to do kind of well-designed interventional human trials so we can say with certainty. But clearly, we know that these exogenous environmental factors that are found in the diet, such as food additives and pesticides, do have an adverse effect. And there's some very interesting evidence that actually having a healthy microbiome can prevent against the absorption into the body of things like pesticides. And one of the functions of the microbiome is a xenobiotic effect, is of helping metabolize medications and helping detoxify compounds in the body. And so there have been a few interesting studies that find that a healthy, robust gut microbiome can prevent against pesticides being absorbed, against heavy metals being absorbed, and that certain probiotics may even help prevent against some of these things. And if you're interested in hearing more about that, you can find my research reviews with AE ProBio. I've reported on some of these studies before. But this is, again, why supporting the health of the microbiota is crucial to maintaining not just gastrointestinal, but systemic health, and focusing on real foods that are free of contaminants is just so important.
Thank you very much for that answer. Absolutely agree with that. So, Dr. Damianos, we're just wrapping up here, but I always like to ask people this: is there anything that you would like to leave people with today? So you see a lot of patients every day. You know,
Mhm.
there's, as we've mentioned this, there's so much interest in the microbiome right now, and consequently, there's also so much misinformation out there. I mean, how do people access good resources like AE ProBio? Are there other resources that you would recommend, or things that you would maybe suggest people kind of stray away from when it
Mhm.
comes
Mhm.
to gut health?
That's a really important question, because as you're alluding to, even the term gut health has kind of been hijacked by pseudoscientists,
Yeah.
and so it's so hard to find evidence-based information about gastrointestinal health. And so I always recommend that people turn to the most reputable sources. And so usually that doesn't include, blogs and TikToks and things like that. Looking at the websites and publications from the major academic institutions is always very helpful. A lot of them now have microbiome centers. We have a microbiome center. UCLA has a phenomenal microbiome and brain gut center. And so, finding information from those centers, and then specific organizations. You mentioned AE ProBio is one that I talk about a lot and always turn people to. And then for probiotics specifically, ISAP is another
Mhm.
phenomenal organization. And they do a lot of basic science as well. So they have both kind of a basic science side as well as a patient facing side. And so try to stay to those types of resources. And if you don't know, talk to your doctor, and if they don't know, try to see if they can direct you to somebody who does. If I can give some parting wisdom, if you will, to people who are suffering from chronic gastrointestinal symptoms, I always tell my patients that there's always a reason, there's always a diagnosis. I see a lot of people who have been told, oh, we don't know what your symptoms are. It might be this, it might be that, it's nothing, or even the worst, it's in your head. And I always tell people there's always a diagnosis. And we just have to work hard and work together to come to that diagnosis. And sometimes it's very difficult. Sometimes it takes a lot of time and a lot of trial and error and testing, but there's always a diagnosis, there's always a name that we can provide. And so, keep advocating for yourself to identify what that is. And as I mentioned in the slide, there's so many IBS mimics. Sometimes it's one of those. Sometimes it's IBS, or there's actually 44 disorders of gut-brain interaction. So there's so many possibilities of reasons that somebody could have chronic gastrointestinal symptoms. But there's an answer, and it might take a while to get there. But if you have that perseverance and that patience and work together with us, we'll partner with you and name that diagnosis or diagnoses for you and help restore you to health.
Thank you so much for that. And, part of this channel, on what we do on this channel, is we want people to feel empowered, right? And so the fact that you mentioned, there is always a diagnosis, and sometimes it's just perseverance, and just keep going, and don't necessarily be too dismayed if someone tells you it's all in your head. Just keep persisting in that, right? And you'll find the right person, the right diagnosis. Dr. Damianos, thank you so much. You've given so much of your time today and your knowledge to us. We're so thankful for this. This session will be up for a limited time, but if you're catching us on the replay, let us know what your biggest takeaway from this session was. If you enjoyed Dr. Damianos' talk today, give us a like. You can consider subscribing to the channel. We are doing live sessions on evidence-based information for you on gut health on this channel for the next 5 weeks, I think. This is our third session. And so, Dr. Damianos, thank you so much for joining us. I do want to do our book giveaway before we tell you about some of the sessions that are coming up. And so we are featuring the book Gut Logic, which is a book that I was able to contribute to. And Graham McKenzie, who is the author of this book, he's also a pharmacist. He is with us, and he's been with us for all of these sessions. He's also said that he will give away one book for every live session to someone who makes a comment or asks a question. And so today, we actually had a great question come in from LinkedIn from Manjeet Hansra. And so, Manjeet, you will be receiving a book today. You will be receiving a copy of Gut Logic from Graham McKenzie. And hopefully you find this book as insightful as many of our viewers have. So I think that pretty much wraps it up. Let me just share some of our upcoming sessions with you so you know what's coming up. Our next session will be next Saturday. We will be covering, today we covered IBS and gut health. Next Saturday, Graham McKenzie and Dragana Skokovic-Sunjic, who is the author of the Clinical Guide to Probiotics in Canada, we will be covering what we're calling gut health jeopardy. So we're going to go over some of the myths and misconceptions about probiotics and gut health. We're also going to be talking about some of the things that are true about probiotics and when probiotics can actually be helpful. So that will be at 4 p.m. next Saturday. And so we look forward to you joining us then and also bringing your questions and comments to us. Graham, do you have anything to add before we close out the session?
Well, I know we have 5 more weeks to go. This is going to be tough to follow up. This was a lot of information, wasn't it? But we do have a lot of interesting topics coming up. And Dr. Damianos, again, thank you. Can't thank you enough for being on here tonight.
Thank you so much for having me.
Thank you so
All
much.
right.
It's been an absolute pleasure. And thank you to all of us who joined on the various social media platforms. Again, give this a like, and I'm sure Dr. Damianos will be appreciative, as will we. And we'll see you in the next session. Thank you so much.